the intravascular pressure is effectively increased. So we need indeed to make the difference between the true preload of the right ventricle and what is limiting the venous return to the thoracic area. And of course, we can mix this with the cardiac function curve so that we have the effective cardiac output. So when we have this increase in the intrathoracic pressure, we have then the decrease in cardiac output that occurs in these conditions. And of course, if we give some volume, we can increase then the cardiac output in these patients. So can we look at the inferior vena cava and superior vena cava to predict the response of fluid? Well, we remember that the ventilation induced cyclic changes in intrathoracic pressure. That basically the mean systemic pressure will be stable over the respiratory cycle. So the gradient between the mean systemic pressure and the right atrial pressure, intravascular one, will vary according to the state of volume responsiveness. And indeed, what we have is that we have some changes in the intrathoracic pressure. The pressure in the right atrium, the gradient will be decreased in the fluid responsive during this the increase in intrathoracic pressure, while in the non-responders, it will not, because the patient will have a high intravascular pressure. And this is nicely shown in this very old data from 60s, showing that mechanical ventilation induced cyclic changes in vena cava flow. And we see that indeed there is initially a decrease in this vena cava flow that occurs just at the onset of inspiration. And of course, during expiration, it goes back to the previous value. So there are cyclic changes there. How can we detect this with echo? We'll discuss later on. But so if the patient is preload responsive, the increase in the intrathoracic pressure and decrease in vena cava flow will be accompanied by some cyclic changes in vena cava diameter by upstream stagnation of flow. If the patient is not preload responsive, the changes in vena cava flow and diameter will be minimal in these conditions, so that indeed we will see almost no changes in the diameters there. And so indeed, we then need to think at what occurs in spontaneous ventilation. Well, we have an increase in the gradient for the venous return that occurs during inspiration due to the decrease in intrathoracic pressure. And how does this translate into changes in cardiac output? Well, when we are on the when the gradient between pressure gradient is quite high, in this condition, we will have a change in cardiac output, which is not the case when the gradient is not high. So what we have here, again, in spontaneous ventilation, because when we look at the diameter and not the flow, of course, in the inferior vena cava, in patients who are volume responsive, we will have there a decrease in the diameter of the inferior vena cava, which is not the case when the mean system pressure and right atrial are high, and so the gradient is minimal in these conditions. On the other hand, when we have mechanical ventilation, as we mentioned, we will have there a dilation of the inferior vena cava occurring only in the fluid responsive mode. So conceptually, we can easily separate fluid responders and fluid non-responders. So what is it in practice? So what do we see in practice in these patients? Well, we have these data, and Antoine Verparon, who is still there, knows very well this data because he helped to generate these data. We can see that indeed we see this dilation of the inferior vena cava during the inspiration in this preload responsive patient. And some groups, including again the group from Bicêtre, and also including the group from Bicêtre, and including the group from Ambroise Paré, so two groups from Paris, almost at the same time, described the same aspects, that the respiratory variation in inferior vena cava diameter can be helpful to guide the fluid therapy and to detect patients who will be fluid responsive. And so one of these trials is this one, and we can see that indeed we have minimal changes here in inferior vena cava. We can see that indeed there is no change in cardiac output after volume expansion. Here we have this vena cava variability during respiration, and you can see that indeed this patient increase his cardiac index after administration of fluids in this condition. And when we look at the individual values of the cardiac index, we can see that indeed most patients here with minimal variability in inferior vena cava did not change their cardiac index, with basically two exceptions here, while most patients here with a significant variability in their inferior vena cava indeed increase their cardiac index in these conditions. And interestingly, they also related the level of variability of the inferior vena cava to the degree of change in cardiac output after fluid expansion. So the more there is variability in inferior vena cava, the higher the changes in cardiac index will occur. And I think that's the concept there. I think it's still very important. We can discuss what will be the best cutoff, and we will do this later on. But remember that if we are very close to the cutoff, the impact on cardiac index will also be relatively modest, while when we have huge changes